Thank you, Teji. And before I start, I would like to thank Dr. Park and Dr. Kim for inviting me again to APSIS, which is a wonderful meeting in Seoul, and I love meeting my friends again. I will be covering mainly PAIVS because of time factor and maybe a bit of Ebstein's as relevant to PAIVS. I think what about PAIVS, what is a bit misleading is that it sounds simple, which is perhaps an extreme form of primary stenosis. But then again, it tends to be more complex than that because we often see abnormalities of the RV morphology itself, the tricuspid valve, the RVOT or outflow tract, the primary valve and the main primary artery, and sometimes the coronary artery abnormalities as well. And I'll be covering these abnormalities as the talk progresses. And in the last part, I will talk about what happens to this morphology as surgeons and cardiologists intervene in the cath lab. So I think what is very important with regards to the outflow tract abnormality is that, yes, it is atretic, but what is more important in terms of management is that what is the right ventricle like? So it can be very mild hypoplasia with nice infundibulum and no RV to coronary connections at the one end, but on the other end, we have very severe form where there is very small right ventricle with hardly anything else apart from the inlet, and quite often what we see is RV to coronary connections. And outside this spectrum, those rare patients who have very severe Ebsteins and the RV is very enlarged and thin-walled. Right, I will start off with those with very nice anatomy, like this pathology specimen here, which I took from Dr. Anderson's book, and this is what it looks like, I suppose, from the angiographic equivalent of such patients, where we have nice three parts, right ventricle, the inlet, as what has been shown earlier in the first talk, the apical part, and the very nice outflow tract, which ends blindly in the membranous atresia. And often they have very marked RV hypertrophy, but nevertheless we have nice complete three components of the right ventricle, fairly normal tricuspid valve, but often there is also tricuspid incompetence and no RV to coronary connections. And when we look at the outflow tract, which is very important as far as management is concerned, is that we have very nice, although thick-walled outflow tract, smooth infundibulum, which is free of obstruction until it ends blindly in the membranous atresia, which is very thin and domed like that. And what we can see, the equivalent of the angiogram, where we have a nice smooth-walled, wide-open infundibulum, which ends blindly in the membranous atresia. But what is nice here is that you have a very well-developed main primary artery, good sinuses development, which cups over that doming part of the valve, and this makes a very good candidate for perforation. Right, I will now go to the other extreme, those with very bad anatomy, and this is basically a single ventricle kind of management where the patient has very severely hypoplastic right ventricle, and quite often what we have together with this kind of anatomy is the RV to coronary connections. One example here, very small inlet with nothing else, and that major connection to the right coronary artery which refluxes into the aorta, as well as smaller connections to the left coronary artery branches, and that is on the lateral view. And this is the pathologic specimen of such patients where we have just an inlet with the rest of the heart obliterated by muscles and a very small valve, but it's hard to see RV to coronary connections in these kind of specimens. So this is another example of our patients where very small right ventricle and two major large sinusoids from the RV, which refluxes back into the aortic root. Then in between these two extremes are those what we would term as intermediate right ventricle, where the right ventricle may have all the three parts present. Maybe the apex is not much here, but what we have is the small versions of the inlet and the infundibulum, as well as a very small pulmonary valve annulus, but there is still a membranous atresia and a decent RV outflow tract, which may be amenable to catheter treatment. And quite often what we have are minor versions of those RV to coronary connections. But this is more representative of such patients, the intermediate right ventricle, where what we have is an inlet, a well-developed outlet, and the apex is quite often almost obliterated except for some of these intertrabecular spaces, and they may have tricuspid incompetence, as noted earlier, and quite often the RA is bigger than the right ventricle, the two parts of it combined. And quite often, they may, not say often, but many will have RV to coronary connections, some with very severe stenosis along the way. So this is what we call as bipartite, which means they have an inlet and an outlet, and not much of the apex because of the thick muscles overgrowth. And again, I think this is fair game for management towards two ventricle, if not 1.5 ventricle management. So this is one such example from the textbook by Dr. Anderson, where we have the two parts, the outlet, which is well developed, and the inlet, but not much else in terms of apical development. And this is an angiographic representation of such patients. What is important is that there is nice outflow tract, smooth wall, very well developed pulmonary valve annulus, thin doming valve, and also very well developed MPA with the sinuses, and therefore it is fairly safe to perforate this valve without a great risk of misperforation outside the heart. And often how we would manage today is usually by the catheter intervention. Next, I'm moving on to the tricuspid valve. Quite often, when you have a very nice three-part ventricle, which is fairly decent size, the valve is fairly normal, as shown here. But because of the high RV pressure, there is often mild or maybe moderate tricuspid incompetence. But quite often, with the smaller ventricles, we may see a dysplastic valve and sometimes a true malformation of the Ebstein of the tricuspid valve. Such as here, where this is from the textbook specimens, we see that this is where the annulus should be, but the septal leaflet is plastered down to the septum and showing the typical Ebstein's malformation with the very dilated right atrium and the atrialized right ventricle. And the RV wall is also very thin here, but here RV wall is very thick. This is one of the patients that our surgeons did, and this is by one of his fellows from Japan who taped this case for presentation at the STS next year. Right. The audio is missing, but what we have is that the tricuspid valve is not normal because it is bicuspid, it's very thick and of fairly small diameter. And then once they do that, they started dividing the thick trabeculations to increase the RV cavity. Right, I will move on to what the echo shows in another patient where the valve is, I think it is normal, it's not Ebstein's, but what we have is a very thick rolled edge of the septal leaflet, which does not move as well as the anterior superior leaflet, and that caused very severe tricuspid incompetence with markedly dilated right atrium and right ventricle. So this is something that is not uncommon. And moving on to the RVOT, as I showed earlier, that what we like to see is that kind of RVOT with very nice wide open infundibulum, membranous valve, which domes, and as well as the nice cupping of the pulmonary sinuses over that dome valve so that it is fairly safe to do a perforation. So as shown here, this is what we term as nice infundibulum because of that very thin doming valve and the cupping over by that blind ending pulmonary outflow tract by that pulmonary artery sinuses, which makes it safe to do. But when you have very severe TR, especially when patients have Ebstein's anomaly, what we see is a very small pulmonary valve annulus. The valve is very thick and very dilated RVOT with not much pulmonary artery sinuses development, and therefore this is a fairly high risk of the perforation wire going outside the RVOT, and the procedure does not succeed. The other component, one of the major things that we see is that, as I mentioned earlier, the problem of the RV to coronary connections, especially in those that have very small hypoplastic unipartite right ventricle, as shown here in the specimen and in this angiogram. And another patient where there is also a very severe constriction, if you can see here, at that part where before it joins the main left main stem pulmonary artery, coronary artery. So this is perhaps one of those that may be RV-dependent coronary circulation. Another example, this is not so bad because we have a bipartite RV, but it is very unusual to see such big RV to coronary connections, but he has this problem with that, in which the contrast just refluxes very freely through that big sinusoids into the aorta, as well as minor connections to the left coronary artery. And the PDA in PAIVS, I think by and large, they are stent-friendly because they comes off from the descending aorta. They have very nice straight morphology, although they may be very long as shown here, but this is basically amenable to stent implantation, except maybe in this kind of patients where we have very long, very tortuous PDA, which makes PDA stenting perhaps a high risk of failure and maybe complications. So lastly, MAPCAs are extremely rare in PAIVS, unlike the next talk by Dr. Bharat. But one of those rare cases where we see MAPCAs to the right upper lungs, and the rest of the lungs is provided by this MAPCA from the other MAPCA to the left side with very hypertensive changes in the left lower lobe. So finally, I just want to mention some of these cases where the morphology changes when we intervene either as surgeons or as cardiologists. Here's one example. It was very, very small right ventricle where the RA is much bigger than the RV, but you have a good outflow tract with very severe tricuspid regurgitation. And with perforation and balloon dilatation, what we have 2 years later is that kind of right ventricle, which has grown significantly. That now the apex fills with color, and you see that on the angiogram that now, instead of just that small inlet, what we have is the apex being well developed because the RV has become decompressed and the RVH largely disappeared, which allows for growth of the apex of the right ventricle. So this is one of the nice examples of how the RV can change with management. Another example where the same patient which I showed with bipartite RV, big sinusoids and small one to the left coronary artery, immediately post-balloon dilatation, you can see spasm of the entire right ventricle, and the sinusoids disappeared. And this is 4 years after that, where still there's no more sinusoids, and the RV has, nice growth of the right ventricle, outflow tract, apex, and the stent has basically become really not relevant to the patient's circulation. My last patient, this is a patient which is very rare because she has 3 parts where you have a good inlet, a small apex, but a very, very small outflow tract. And this is the echo representation. Because of that, we think that this patient is not going to have a good 2 ventricles, so she received a Glenn shunt at about 15 months. But then again, when you look, maybe we should do an overhaul to widen up the RVOT and the apex, see if we can develop a 2 ventricle circulation. And this is the surgical video, again, from our surgical fellow, where the pulmonary artery is open, that is the valve, and it's very, very tiny. If you notice that, that is the RVOT, which is now the outflow tract is divided. Muscles are resected, and from there, sorry, I don't have the audio for you guys, but this is what the surgeon did to remove as much muscle as possible, especially once the outflow tract is much bigger. They went down right to the apex to incise more muscles. Just 1 or 2 more minutes, and I'll finish. And then they put monocups that widens up the RVOT from that small to a much bigger RVOT. And this is the cath after that. This is before, and now what we have is very nice RV apex, very nice outflow tract. And now instead of having the gland there, it becomes a problem because the RV pumps a lot of blood during the sinus beats, where the blood just goes up to the ISVC, and this patient developed SVC syndrome, and therefore we had to take down that gland shunt, and the patient has a nice 2 ventricle circulation. But still, it is something which is very recent. There might still be problems as the patient grows with regards, especially to the outflow tract. So just in summary, PAIVS, the name may be simple, but I think the anatomy is not that simple because you can have multiple abnormalities, especially of the tricuspid valve, RVOT, the pulmonary valve, as well as the coronary arteries in those that have small right ventricle. And the PDA, too, is an important part of the evaluation. And one thing that is what we see in the modern cardiac and surgical practice is that with management by the surgeons and the cardiologists, the morphology of PAIVS is something that is changing as the patient grows. Thank you for your attention.